What I'm going to talk to you today about, and there's no microphone, so I probably need to stand here simply so other people can hear me, is the whole concept of cardiovascular homeostasis and how you can, right this minute, this second, see any of your patients at the bedside right now in our ICU and know exactly what's going on with them and actually predict their response to therapy. As all of us have to do, I have to show you my conflicts of interest. And these are my important conflicts of interest. This is my wife and my 3 children, Daniel, Stephanie, and Joe. And these are my unimportant conflicts of interest. I am or was a consultant to every known hemodynamic monitoring company that I'm aware of. I have received grants in the past from several companies and have an active grant now from Edwards. And probably my most important conflicts of interest is I'm a principal investigator on 3 NIH grants, and if you don't think that's a conflict of interest, you're kidding yourself. Okay, there's a hemodynamic monitoring truth, and that is that no monitoring device, no matter how insightful its data, will improve outcome unless coupled to a treatment which itself improves outcome. And thus what we really want to know is what is the information I need to make my patient better. So let me give you a case presentation. This is a 65-year-old female that's admitted from the emergency room with septic shock and acute respiratory distress secondary to peritonitis, which was thought to be due to a perforated diverticulum. At the time of admission to the ICU, she has a PO2 65 under mechanical ventilation, 28 frequency, 540 tidal volume, FiO2 and PEEP as you see. She's hypotensive with a systolic of 94/40, mean of 58. Heart rate's 123 sinus. She's got a CVP of 9. Cardiac index is 2.6. Her mixed venous oxygen sat, they put a PA catheter in, I presume, is 54%, and she's got a lactate of 6.4. She's already received 3 liters of fluid that have been slam dunked in to her as surviving sepsis requests. And she is now on 0.6 mics per kilogram per minute of norepi. She's oliguric, she's got her platelets are a little low, and her APT is high. Okay, what does she need? Does she need fluids? Does she need increased ionotropy? Does she need increased dobutamine? The answer is, from what I've told you now, unless you do something else, you have no idea. The presentation of the cardiovascularly unstable patient can be unbelievable, especially in septic shock. But don't panic, because it can be evaluated in a systematic fashion. But what I want to stress to you is that measuring only one parameter, such as cardiac output or blood pressure, doesn't work. When we think about how to manage patients, there are actually only 3 primary clinical problems we have. The first is how to identify people that are sick before they get to where this lady was before and treat them early. The second is to determine the most appropriate therapy to treat the primary cause. Now, I assume, by the way, in this lady's case, they would do cultures and start appropriate antibiotics, but we're talking cardiovascular management now. And then the third one is, how do we train all of you and people out in the field to do the same thing? Well, today we're only going to focus in on how do you identify the patient and give the most appropriate therapy. Well, what I wanted to show first, and this is an important slide, is that knowing somebody's blood pressure doesn't tell you anything about their cardiovascular status. What we plotted here on a 3-dimensional graph is on the systemic vascular resistance, cardiac power, which I will describe in a moment, but this is a clinically relevant way of looking at performance of the heart. So it can be really, really good or really bad. And mean systemic pressure, which is the effective circulating blood volume. And this was calculated using a simple computer program called Symbiosis, which is commercially available. And all you did is say, for a 70-kilogram male that's 55 years old, what is the combination of vasomotor tone, cardiac performance, and mean systemic pressure that would give me an arterial pressure of 80 millimeters of mercury. And as you can see, you can have 80 millimeters of mercury mean arterial pressure in severe heart failure with cardiac function very low, down here, very low function. You can have it with hypovolemia if vasomotor tone is increased, and you can have it with sepsis. Furthermore, knowing cardiac output as a single solitary variable tells you nothing either. Because again, you can have hypovolemia, heart failure, or sepsis with the exact same cardiac output, depending upon the balance of vasomotor tone, blood volume, and contractility. Adding the two together makes things a little better, yet I can still have hypovolemia and heart failure with intersection of the two. And thus the reality is that we need to understand more clearly the absolute ventricular performance, blood volume distribution, and blood volume of our patients if we're going to give them volume, vasoactive drugs, and inotropes with the goal of reversing shock. Hemodynamic monitoring and outcomes are very important. So what I'm going to talk to you about is bedside cardiovascular physiology. And what we're going to do is look at why do we have a given cardiac output and how can we increase it so as to reverse shock by understanding the effective circulating blood volume, which we measure as mean systemic pressure, cardiac performance, and blood flow distribution. And what we're also going to do is look at vasomotor tone in a new way, which is arterial critical closing pressures and arterial and venous resistance. And I want to stress at this point right now that everything I'm saying you can do at the bedside right now. We have the tools, they're not fancy. It just requires that you look. The cast of characters that have been interested in looking at the blood volume start originally with Arthur Guyton, who popularized the concept of venous return and mean systemic pressure. My mentor, Saul Permit, took it a little bit further, and then Adrian Verspula and Joss Johnson, who are colleagues of mine and continue to be colleagues to this day in Rotterdam and then in Leiden, the Netherlands, have been working on it. Jim Robotham looked at it for a long time before kind of retiring. And recently I've been involved with the University of Leiden in a PhD thesis for the last 5 years of jan09 Maas, and this is her. She is an MD who just got her PhD, and I'm going to show you a significant amount of the work represents that she was first author on that we did as part of her PhD thesis, in which she asked the question, can I assess the effective circulating blood volume of my patient, and can I use it to diagnose and manage patients? And we told her at the time, of course you can. We published this data years ago, but no one's used it clinically, and so she said she would like to try, and I'm going to share that with you. Well, what are the determinants of cardiac output? Well, by Starling's law, we talk about preload, afterload, heart rate, and contractility when we're looking at cardiac function. But we also have to consider the circuit. And the circuit is the concept of where does the blood flow to and does it drain back to the heart? You can have the strongest heart in the world, but if you have got no blood volume, you're dead. And if you've lost a vasomotor tone and can't maintain blood pressure, you'll be dead anyway, and I don't care what your heart is. And so you have to have vasomotor tone, blood volume, and cardiac function together to be able to work. And to focus only on one is to be myopic and to hurt your patient. The key to Guyton's approach, however, was to say that right atrial pressure is actually the central point determining cardiovascular function because it is the intersection between cardiac function and circuit function, and that the role of the heart in terms of maintaining blood flow is simply to keep the right atrial pressure as low as possible so as to maximize the measurement of venous return. Now I have a question here. I'd like to ask the audience for a show of hands. Most of you are clinicians, I think. So I want you to raise your hand. Who here has measured venous return in their patient at the bedside? Raise your hand. Okay, nobody, I see. Okay, who here has measured cardiac output at the bedside? Raise your hand. Well, you've all measured venous return because cardiac output and venous return are the exact same thing, exactly the same, millimeter for millimeter at the exact same time. So every one of you has measured venous return. You just never thought of it within that perspective. Okay. Venous return is the primary determinant of cardiac output. The two must be equal or you're in pulmonary edema and you can't live that way for more than a couple of minutes max, or you're oliguric in the heart. Mean systemic pressure, which is the upstream pressure that's draining the blood back to the body, is a function of the total blood volume, vasomotor tone, and the distribution of the blood. And it's really the effective circulating blood volume. And almost everything we do, including the use of dobutamine, primarily affects cardiac output by altering the effective circulating blood volume and venous return. Therefore, the pressure gradient between the right atrium and this upstream venous return pressure, or the pressure gradient for venous return, becomes the primary determinant of cardiac output in most of our patients. So what I want to do now is go through the logic of what I'm saying and then give you real examples in human beings. And all that I'm going to show you is in peer-reviewed published papers that are already out and have been published in the last 5 years. Okay, if we look at cardiac function and we just increase right atrial pressure, we would see that we have a cardiac output curve, such as we increase the filling of the heart, cardiac output goes up. And I'm calling cardiac output Q because in physiology terms, that's what's called. And we would say, okay, if our right atrial pressure is 0.5, I'll have a cardiac output of 4 liters or something like that. Well, Guyton said that you need to look at it from the other side. Since cardiac output is venous return, if you raise right atrial pressure, you'll increase the back pressure against which blood flow can come from the body, and cardiac output will fall. And the increase in right atrial pressure will cause the venous return to fall, and you'll see an absolute negative slope. And when the venous return is 0, right atrial pressure equals the pressure in the reservoirs, and in fact the zero intercept point is mean systemic pressure. And we use this concept of the zero intercept point all the time in estimating what the effective blood volume is. The slope of the line is 1 over the resistance to venous return, which is really conductance. So if I give drugs such as norepinephrine, I'll increase the resistance to venous return. And if I give dobutamine or nitroprusside, I'll decrease the resistance to venous return. So if the resistance goes up, the slope gets higher. The resistance goes down, the slope gets lower. Venous return is cardiac output. They are the same thing. And they're equal to this pressure gradient divided by the resistance to venous return. So if I had my given cardiac output and I put the venous return curve, you can see that there exists this one and only one point, which is called the equilibrium point, that says that in you and I and our patients, there exists one and only one cardiac output we can have, which is a function of our ventricular pump function, blood volume, vasomotor tone. And this equilibrium point is what we're trying to manipulate when a patient's in shock, or when they're in shock and they have their adaptive functions, they manipulate to stay alive. Okay, so let's go through this a little bit. Let's assume that I have a normal ventricular function, so I have a central venous pressure of, oh, I don't know, 2 here, I guess it is, and the cardiac output's here, and I have a normal function. Well, what happens if I have impaired contractility? If I have impaired contractility, the ventricular function curve is shifted down, and for the same blood volume, I see that the CVP is higher, but cardiac output is less. Most of the time, if this is done chronically, the patient will fluid retain and will increase their effective circulating blood volume, or you can give them volume to shift their venous return curve to the right, and you would see that the CVP rises, and now they have a normal cardiac output again. And you refer to this as congestive heart failure, but I refer to this as congestive heart success, because this is the only way that the heart can maintain cardiac output within the context of impaired ventricular function. And this is why all patients in heart failure have an increased effective circulating blood volume. Okay, what determines mean systemic pressure are blood volume and blood flow distribution statically, but dynamically it's where the blood flows to. So if I had a given venous return curve that looks like this, where my venous return is here, so whatever my right atrial pressure, that's my cardiac output, and that's my normal venous return curve. If I am hypovolemic, for the same amount of CVP, I'll have a lower cardiac output. And if I'm hypervolemic, I will just increase my mean systemic pressure, not alter venous return, and thus I would see that I would have more volume. And if you wanted to put a ventricular function curve on it, you would see that with volume loading, you'd be going up right atrial pressures from here to here. You can do the exact same thing with vasomotor tone. If you vasodilate someone, you will cause their effective circulating blood volume to fall, their mean systemic pressure to fall because you vasodilated them, and their CVP will fall and their cardiac output will go down. And if you give them a vasopressor, you'll increase their mean systemic pressure because you've increased vasomotor tone, and cardiac output will go up. Thus, I can take a hypovolemic patient and give them norepinephrine, and their cardiac output will increase. That's why we tell you don't give vasopressors to hypotensive patients. unless you've also restored their blood volume, because their cardiac output will go up initially because you're increasing vasomotor tone, and it'll stay up almost until the moment they die. So giving norepinephrine alone can be dangerous. How do you measure mean systemic pressure? Well, the original way that was done was by Arthur Guyton in an animal lab, in which he did a total circulatory arrest for 15 seconds to open up an arterial venous fistula and looked at the equilibrium pressure. That's not really clinically possible. Maybe in cardiac bypass surgery. It's been done a few times in a study that was published from Philadelphia about 20 years ago, but it's not the sort of thing we can do. So years ago, I proposed that we look at the dynamic changes in right atrial pressure during slow positive pressure breathing and create instantaneous venous return curves by looking at the stroke volume in the right ventricle compared to the right atrial pressure, and I'll show you that in a second. Adrian Vespula said, why don't we look at just an inspiratory pause, increase in the right atrial pressure, and see how cardiac output falls, and give a whole bunch of CPAP levels and be able to create a venous return curve. Jeff Parkin, who was the original teacher of one of our ex-fellows, Ronaldo Bellomo, said, I can calculate using Guytonian physiology. If I know the resistances and the compliances of the body, I can calculate instantaneously mean systemic pressure in anyone, as long as I know the arterial pressure, cardiac output, and right atrial pressure. And then finally, Moss and I suggested that since in equilibrium, all vascular beds see the same right atrial pressure, so they all have essentially the same mean systemic pressure. If I just have an arterial catheter in my radial artery and rapidly blow up a blood pressure cuff on the forearm, the pressure that this falls to after about 20 seconds ought to equal my mean systemic pressure. So this is the first way we looked at it. And this is an intact animal. And just look at positive pressure breathing. You can see with positive pressure breathing, pleural pressure rises, causes right atrial pressure to go up. And you see that right ventricular stroke volume goes down. So as the right atrial pressure rises, right ventricular stroke volume falls. So what we did is I simply plotted the falling stroke volume to the increasing right atrial pressure. And I measured an instantaneous venous return, and then because it was an animal model, we fibrillated the dogs, opened up an AV fistula, and the red line is the actual mean systemic pressure in that patient, and that dog, and then we repeated it again with volume loading. And in fact, in all the animals, this is what we saw, and indeed, the correlation between our estimated instantaneous mean systemic pressure and the stop flow was extremely tight. So I'm going to show you some data in a minute using instantaneous venous return curves to calculate mean systemic pressure. Well, Adrian Vespula and Josh Johnson said, well, I don't like Pinsky's method because when you increase right atrial pressure, you might be creating a capacitor in the venous system, which is really not steady state. So what they said, that instead of doing the positive pressure breath, which causes the right atrial pressure to rise as the stroke volume falls, we'll compare that to an inspiratory hold maneuver in which we are going to have a fixed increase in CVP and a fixed decrease in stroke volume. And when they did that, they found, to their surprise, that in fact their calculation of mean systemic pressure and mine were one and the same. And so they said you can use either one. Moss then said, if you guys are correct, why aren't we doing this in the ICU? So we said, sure, let's do it in the ICU. So in a paper that we published in 2009, which was her first paper in her PhD thesis, we did the inspiratory hold maneuvers, and this is an example of beat-to-beat cardiac output measurements. You can see them here. And this is inspiratory hold, so this is one cardiac output, one value. And what we did is we measured it at 5, 7.5, 10, 12, and 15 centimeters of water CPAP, which you only have to hold for about 10 seconds or 15 seconds. It's not dangerous. And in fact, in that study, we had post-op cardiac surgery patients, and we looked at them in terms of their venous return curve. As you can see here, the different values. Put the head up, and we got a different mean systemic pressure, and we gave them volume, and it went up. So we can measure this with the inspiratory hold maneuver. That's kind of hard to do at the bedside because you have to do CPAP for a bunch of measures and measure cardiac output using one of the multiple cardiac output devices like FlowTrack or LIDCO or PICO, and it was a bit of a pain. And so Moss said, why don't we just do a vascular occlusion? We got an art line in. So what we did here is this is the venous line on IV, and an art line in the same hand, and we just did a quick vascular occlusion, and you can see that they equilibrated at about 20 seconds. And this is called the P arm, pressure arm, and it equals mean systemic pressure too. And when we compared it to the the CPAP method, which was acceptable, you can see that it's a pretty accurate measure. And in fact, more importantly, the changes in mean systemic pressure followed. So just by having a blood pressure cuff on a person who's got an art line in and blowing it up really fast so that no blood flow can change, and looking at the pressure, 20 seconds later, you know the mean systemic pressure of your patient. Well, Jeff Parkins said, that's nice, but wouldn't you like to know it every single heartbeat continuously? So what he did is he said, if we assume that there's a certain relationship between mean systemic pressure and cardiac output that has to do with the amount of blood that's in the stressed and unstressed volume and the resistances, I should be able to create a very simple formula, which I can easily plug in, which is published, and we can put in an Excel sheet if you want. We have it in an Excel sheet in our lab, but we can do it anytime you want in the ICU. And we can measure cardiac output. Well, we looked at that one as well, and we found that it had a systematic bias. The slope of the line was 0.7, so if you divide by 0.7 the values for your cardiac mean systemic pressure by the Parkin method, it is going to be accurate. But more importantly, the changes by the instantaneous method are accurate. So now I have two methods that I can give you right now that you can go out and measure the effective circulating volume in your patient. Why do you need to know it? You need to know it because it determines vascular state, volume responsiveness, and the response to vasopressors, inotropes, and vasodilators. If you know mean systemic pressure, you know the effective circulating blood volume of your patient. Because mean systemic pressure is a function both of the stressed volume that you're distending plus all the unstressed volume. Changes in mean systemic pressure will be a function of how you distribute blood flow against really tight vascular compartments like your legs and your head, and really flabby compartments like your splanchnic belly blood flow. And changes in mean systemic pressure to changes in volume are actually your compliance. Now, if anybody here likes to hunt and you catch a rabbit or a deer or something, you know that you got to hang it up by its hoofs, slice its neck, and allow the blood to drain out. Because if you don't, and you just open up some wounds, the blood won't fall out of the body, and you'll have meat that doesn't taste good. So you have to always let the blood drain. And that's because if you allow the pressure to fall to zero, there's still a lot of blood left in the body. That's the unstressed volume, so you'll have gravity to take effect. Well, that's true also in you. So if this is the relationship between blood volume and mean systemic pressure, and this is somebody's mean systemic pressure, there's your blood volume, there's your mean systemic pressure. As you increase the blood volume above a certain point, the mean systemic pressure rises. However, the blood volume that you needed in your body up until the point that there would be any measurable mean systemic pressure is the unstressed volume. And in you and I, it's between 70 to 80% of the total blood in our body doesn't even contribute to mean systemic pressure. And that's because we have yet to distend enough the veins so that they can actually generate a pressure. It is the top volume, which is the stress volume. Now, one of the things we can do is we can measure the vascular capacitance, which is the total blood volume to vascular pressure, but I don't know why I'd ever want to know that. What I really care about is the compliance. What I care about is if I give volume to a person, will cardiac output go up because the driving pressure for venous return increases? Yes or no? That's what I care about. So let's take a look. If I were simply to give volume to a person, I would increase their blood volume, and this would cause the mean systemic pressure to rise based on their vascular compliance. However, what the body does is it redistributes blood flow away from the really compliant parts of the vasculature to other parts of the vasculature which are stiffer, and it causes a significant decrease in unstressed volume, and it can do this in 5 to 10 seconds. And look at how much I can increase mean systemic pressure. And furthermore, if I were to have somebody have blood drawn from them and they see the blood coming out and they go, oh shit, and they faint, and I have vasovagal syncope, they haven't lost much blood. What they've done is they've vasodilated. And by vasodilating, what they've done is they've effectively increased blood flow to all the blood circulation. The effective blood volume falls to close to zero. They don't have any mean systemic pressure, and they crash. Okay? That's what happened to Hillary Clinton when she fell and got her subdural hematoma. Okay, so it shouldn't surprise anyone in this room that there's absolutely no relationship between central venous pressure and your blood volume. And why you would even dream of using central venous pressure to assess volume status, I do not know. This study was published by Shippey and Will Shoemaker years ago in 1984 and was brought back in by Paul Merrick, who simply copied the picture. And it's really interesting to see on the papers, they always cite his reference paper on this, even though the original paper was by Shippey et al. And so there is no relationship between right atrial pressure and effective circulating blood volume. We were able to measure mean systemic pressure in the patients in the ICU who had had cardiac surgery. Remember, the mean systemic pressure rose as we gave volume. Well, there's your volume. There's your mean systemic pressure rising. There's your volume. So that's the compliance of the vasculature. So looking at this years ago, in 1986, with George Matuszak, when he was here as a junior faculty member in our lab, we asked the question, can we measure the effects of sepsis, in this case acute endotoxic shock, in a canine model? And so we just basically took animals and we fluid loaded them 100, 200, 300, 400 mLs. And you can see this would be considered like a Starling curve. But then these are the instantaneous stroke volume right atrial pressures. And then we induced endotoxic shock and did the same thing. And as you can see, if you calculate the zero flow intercept point, which was done as a least squares estimate, you can see that these are the mean systemic pressure changes that occurred under control conditions. And in sepsis, you can see the slope of the line is less. So in sepsis, there's an increased resistance to venous return. Why? Because in sepsis, in the dog at least, there's splanchnic constriction of the liver and increased hepatic outflow. That's the reason why your liver swells up in sepsis. It's because your gut swells up in sepsis and you get ascites, is because the liver has an increased resistance and the back pressure causes the fluid to come out. So we were able then to calculate the change in volume to the change in absolute volume measured using indocyanide green to know the real blood volume. And you can see that there's absolutely no difference in the compliance of the vasculature under control in endotoxic states. The only thing that's different, and it is real different, is that the effective circulating blood volume increases because the unstressed volume rises in sepsis. Why? Because you vasodilate, so you put more blood out into the periphery and your unstressed volume falls. That's the reason why you immediately get hypotension that's volume responsive in septic patients when they come in. Because even though they haven't lost a single bit of fluid transitating through the capillary leak, they've immediately got distribution of blood flow to the whole body. So endotoxemia increases resistance to venous return by spinning more blood through the liver and increases the unstressed volume. So to look at this as well, using arm equilibrium pressure, Greets et al. Looked at patients who were post-op, and we gave them 100 ml volume boluses, and we measured the compliance changes as mean systemic pressure versus changes in volume. We were using the P arm, and we had patients who were volume responsive and patients who are not volume responsive. And what we found is that patients who are volume responsive, and this is that blood pressure cuff up for 20 seconds, it's really fast to do. The reason they were volume unresponsive wasn't that they had impaired contractility, they just were fluid loaded. They had 30% of their total blood volume was in the stress volume state. They were already volume overloaded. Their mean systemic pressures were already somewhere between 25 and 35. You can't do much better than that. And so by just knowing mean systemic pressure, I know if a person's going to be volume responsive or not. The primary mechanism by which your patient and you change your venous return is by altering blood flow distribution to alter your unstressed volume. When you do that blood flow distribution change, you alter dynamic effects as well, and they're important because if I put more blood flow to the gut, I have a higher outflow resistance and more compliance. If I avoid the gut, I have all that blood going to the rest of the body with lower resistance, so I can increase cardiac output. So if I put all the blood in the body into the inferior vena cava circulation, everything below the diaphragm, and look at what's going to happen to mean systemic pressure, it goes up like this. But if instead of that, I were to put all the blood into the superior vena cava, because your upper extremities and brain are much stiffer in terms of the vasculature, I need much less blood to get a significant increase in mean systemic pressure. And thus shifting blood from the gut to the rest of the body without changing a thing will increase your mean systemic pressure. If you put the blood into the gut, you decrease your mean systemic pressure. So Rothy looked at this, and what he did was he took an animal and he simply cross-clamped the splanchnic spiromesenteric artery and showed that the aortic flow decreased. And he measured the portal venous flow, and he showed that obviously it would fall off over time. And the difference between those two was an autotransfusion into the rest of the body of about 45 mLs. So he compared that to not causing cross-clamping of the aorta, but just increasing vasomotor tone to the gut by stimulating the stellate ganglion. And when he did that, he saw that the blood flow to the arteries didn't fall as far as here, of course, but what he also found at the same time was because of the increased vasomotor tone, there was an actual increase in blood flow out of the portal vein, and the total amount of volume that came out was 71 ml. So I can almost double the amount of blood I get from the rest of the body if I increase vasomotor tone by decreasing blood flow to the gut. So if I increase vasomotor tone, I'm also going to decrease vascular resistance. So increase vascular resistance. So if all I did, remember I showed you the picture that if I increase mean systemic pressure by increasing vasomotor tone, I'll increase my mean systemic pressure to here. Well, that's not really true. What you're really doing at the same time is you're increasing the resistance to flow because you have less parallel circuits. So giving norepinephrine may not cause cardiac output to go up that much because the resistance to venous return falls. And furthermore, vasodilation is supposed to really cause cardiac output to fall, but maybe it doesn't because it opens up more parallel circuits and the resistance to venous return is less, and you may see actually minimal fall in cardiac output. Well, we're going to look at that now as a series of points in human beings, sepsis and post-ops, in which they're going to be given drugs that are going to alter vasomotor tone, and we're going to see what happens. But before I do that, I have to remind you what contractility is all about. So let's start here with this. This is a study that we recently published in Clinical Monitoring and Computational Biology, in which we looked at the effects of giving dobutamine to patients who had heart failure. And you can see that with dobutamine, we saw that there was a decrease in the resistance to venous return. Your mean systemic resistance fell, and there was vasodilation. Well, if cardiac output went up with dobutamine, it can't be primarily because of an increase in contractility. It has to be because of an increase in venous return. How could I have an increase in venous return from dobutamine? Two mechanisms. One, right atrial pressure falls, so more venous return, but dobutamine's a vasodilator. It decreases arterial tone and decreases mean systemic pressure. So the only way that I can increase cardiac output in a patient with dobutamine is to decrease the resistance to venous return. And that's exactly what we see. Dobutamine decreases right atrial pressure and resistance to venous return, which causes cardiac output to go up. So if we just focus now only on the very low pressures down here, which is the venous return, you can see that with dobutamine, and this is our published paper, there is a significantly decreased resistance. So what do I think is going to happen? If this is my normal ventricular punction curve, as I increase right atrial pressure, cardiac output goes up, and there's my normal venous return curve. If all I do were to increase contractility, and I'm really increasing contractility here with a super strong response, and this is probably not even possible, but let's assume it was because I'm going to be Superman here, I would see the CVP falls to 0 and the cardiac output goes up this much. But in fact, I forgot that dobutamine is altering venous return. And what we see is that mean systemic pressure falls, but the resistance goes down. And in fact, with dobutamine, we see a much higher cardiac output than would have been predicted at all from just having a increase in contractility. And so this is what we showed. The reason that cardiac output goes up in patients who have heart failure is because we increase venous return. This will not work if your patient's hypovolemic. If you want to prove that your patient is hypovolemic, give them dobutamine. Their blood pressure will fall real fast because in all cases, you will cause their mean systemic pressure to go down. Okay? Now let's talk about ventricular pump function, and then I think I'm almost through. We can consider the effectiveness of function as how much of a venous driving pressure, which is the mean systemic pressure minus right atrial pressure, relative to mean systemic pressure I need to cause cardiac output to go. So let me give you an example. Remember, we had our ventricular function curve, and we had a good heart and we had a not so good heart, right? Remember that? Well, instead of that, let's put real numbers in. Let's say that the normal heart had a right atrial pressure of 2, and the bad heart here had a right atrial pressure of 7, and of course your mean systemic pressure is 12. So if I were to calculate it, this good heart would have 12 minus 1, or over 12, or a cardiac power of 0.92, whereas this one would be 12 minus 7 over 12, or 0.41. So just by looking at the mean systemic pressure and right atrial pressure, I know the effective performance of the heart. I don't need to calculate in-systolic elastance. I can do it simply. So let's give volume. And as we give volume, we're going to increase our mean systemic pressure, which now all of you can measure at the bedside. You already know your right atrial pressure. And let's give as the example this patient here or that patient here. You would see that in all cases, their cardiac power would go down. So I can plot the driving pressure of venous return, which is mean systemic pressure minus right atrial pressure, over the mean systemic pressure. And if the slope of the line is 1, that's a purely E of 1. If it's 50%, it would be half of that. But if it's about 30%, that's getting into danger. We're going to call that a dangerous range. And if it's down to 20%, you're in deep weeds. So let's see what happened to those two curves I just showed you. Here was the good heart, and here's the not so good heart. Well, here's the good heart. As we go and calculate out the numbers, you can see that as it starts to get into the flatter part of the curve, it starts to go towards the lower cardiac power. Whereas the not so good part was already here to begin with, and it very rapidly gets into the bad power range. I didn't need to measure anything but mean systemic pressure and right atrial pressure to know this. It's as simple as that. So we can look then at these are real human beings from our ICUs. I took this data about 5 years ago now. And these are people who have heart failure here, hemorrhage, and sepsis. And all they did was volume load them. I think it was 500 mLs of saline, or I'm sorry, John, maybe it was a balanced salt solution. And you can see that the hemorrhage patients increased their cardiac performance, as did the sepsis, but the sepsis patients didn't increase their mean systemic pressure. And the heart failure patients, you didn't do squat to. So I can follow them dynamically. So I can look at resistances in terms of venous resistance. Now I want to look at arterial resistance for a second. There is no such thing as systemic vascular resistance. All the resistance of the body is isolated in a thin little area between the arterioles and the precapillary sphincters. And when we think about it, we need to measure it. So in collaboration with Jose Marquez, we went into the operating room, put a flow probe on the aorta of human beings, put our finger on the IVC and measured stroke volume and arterial pressure. Here's right atrial pressure, stroke volume as it fell. And in human beings, you can see that over the normal physiologic range, pulse pressure and stroke volume are in fact equal. So I can now, by looking at the dynamic changes in pulse, in mean arterial pressure and stroke volume, I can calculate the slope of the change in pressure to flow, and that's going to be resistance. But more importantly, the zero intercept point will be that critical closing pressure in the arterioles. That's the pressure at zero flow. If the resistance goes up, I need a significantly higher pressure for the same increase in cardiac output. And if the resistance goes down, I need less. So let me give you an example. I can have an increase, a fall in mean arterial pressure because my critical closing pressure goes down with no change in resistance, or because I vasodilate and have decreased resistance. Mrs. Schwartz in bed 4, you're called by the nurse because she's getting septic and she's now hypotensive and tachycardic. Give her a liter of balanced salt solution, Ringer's lactate, which is my favorite. So the nurse says, okay, great, and you do it. Her blood pressure comes up. 2 hours, and what's happened here? What's happened is that you had a decrease initially in your critical closing pressure because sepsis causes vasodilation, but you hadn't changed arterial tone. So with the increase in cardiac output, blood pressure came up. But then they call you 2 hours later. Mrs. Schwartz is hypotensive again. Did you give her some more fluid? Yes, we gave her 2 more liters and she's still hypotensive. Ah, she needs norepinephrine. What has happened? Now, inducible nitric oxide synthetase and other processes have come out and have decreased the resistance to venous return. And you have to give a vasopressor now to maintain mean arterial pressure in an adequate way to have blood flow to the heart and the brain. And this is clinically exactly what you see. So just by noting the change in pressure to volume in a cardiac output responsive patient, you know vasomotor tone. So looking at this, since we did our inspiratory hold maneuvers, remember, here's your inspiratory hold. This is an airway pressure here, in this case of 20, but normally it was less. Cardiac output goes down. We not only had CVP, but we also had mean arterial pressure. Here's our venous return curve. And that same human being, here's your ventricular function curve. This is your critical closing pressure. Arterial resistance is significantly less than calculated systemic vascular resistance. Think of how wonderful this is. How do you think patients can double their cardiac outputs without a change in mean arterial pressure? Do they change the slope of their resistance? No, they just open up more parallel channels so they can get more blood flow to where it's metabolically needed. If the slope of the line doesn't change, they just parallel shift it to the right. That's the normal way in which cardiac output increases without a change in blood pressure in our patients. Interestingly, as the resistance becomes really, really low, the difference between absolute systemic vascular resistance, shown here as the dotted line, the line of identity, and calculated resistance become near each other. So at very high resistances, you're grossly overestimating true resistance. And in fact, what you have is a vascular waterfall between this critical pressure and down there, and there's really essentially no pressure there. So we can examine everything now except ventricular pump function, and for that we're going to look at pulse pressure and stroke volume variation. As jan09 showed in the ICU, if you're looking, in the animal lab, if you're looking at left ventricular pressure volume loops and you give a positive pressure breath, you can significantly decrease the preload on the left ventricle during each breath, and if you're volume responsive, you'll see a change in stroke volume. But these are dynamic, instantaneous changes which don't occur in the steady state. And they were nicely shown by Young-Gu Kim in our laboratory, in which we looked at left ventricular pressure volume loops and color-coded them into where they were in inspiration, from end expiration up to end inspiration. And as you can see, with inspiration, you get a decrease in end diastolic volume. That's a decrease in preload. And the difference between end diastolic and end systolic volume is your stroke volume, and you get a pulse pressure variation. And indeed, if you were to look at it, every positive pressure breath alters end diastolic volume. So I can have a good heart and a not so good heart. And if I'm in a volume responsive area, both hearts will show a stroke volume variation. If I fill them up enough, the not so good heart will no longer show a stroke volume variation. The good heart still will. Eventually, neither heart will show a stroke volume variation. And I can look at either stroke volume or pulse pressure. This is data from our laboratory a couple of years ago now, in which you can see the stroke volume of, here in gray squares versus dots for pulse pressure. See, they both kind of track each other. So this is pulse pressure and stroke volume variation. Well, I can capture that just by looking at arterial pulse pressure variation. And with Frederick Makar and Jean-Louis Thibault, we did that. And what we did is we said, what is the maximal pulse pressure and the minimal divided by the mean? And we call that the pulse pressure variation. And in fact, if you had no pulse pressure variation, you were not volume responsive. And if you then looked at how much the cardiac output decreased as you added 10 of PEEP, you didn't have any. But the more volume responsive you were, the more cardiac output fell if you had PEEP. So just by looking at the pulse pressure variation during positive pressure breathing will tell you whether cardiac output will fall or not during ventilation. Similarly, in septic patients that we gave 500 mLs of colloid to, the greater the baseline pulse pressure variation, the greater the increase in cardiac output with a really high value. Since this is the test, you can do a receiver-operator characteristic, and a threshold value somewhere around 13%, 10% for pulse pressure and stroke volume variation predict volume responsiveness. And Paul Merrick did a nice meta-analysis on this recently of many studies showing that in fact these are extremely accurate methods of identifying volume responsiveness in your patients. And it really doesn't matter where your curves are or what their shapes are, because if you're looking between 2 points, If they're not volume responsive, you won't see it. So this is the beauty of looking at pulse pressure or stroke volume variation. And in fact, it had an excellent positive and negative predictive value. Last thing I'm going to talk about, because this is an awful lot, and I'll show you how I use it in humans, is arterial tone. Now, instead of looking at mean arterial pressure, let's look at arterial pulse pressure and stroke volume. Let's say I have a given arterial pressure and a given stroke volume. What happens if I drop a beat and don't have a stroke volume? Well, I won't have a pulse pressure. I'll still have a mean arterial pressure, but I won't have a pulse pressure. And if I double my stroke volume, I'll increase my pulse pressure. And the slope of this line is called arterial elastance. And this is the dynamic relationship between pulse pressure and stroke volume. So let's take a given person, and they have a given arterial pressure and stroke volume. And for the same stroke volume, the pulse pressure is less. They must have a decreased arterial tone. And for the same stroke volume, if the pulse pressure is higher, they must have an increased arterial tone. And this is not physiology. This is physics. This is how we define things. So this must be true. So, for example, if I have a given cardiac function curve, what will happen to the arterial pressure is totally a function of vasomotor tone. If my tone is low, even though cardiac output will go up, blood pressure won't. And remember, in a hypotensive patient, you want the blood pressure to go up. So Murnaz Hadian, in our CTICU, looked at patients who came back post-op and measured stroke volume and pulse pressure variation. And in all these patients, they got nitroprusside to decrease vasomotor tone because they were too hypertensive at the time. And what she found is that the pulse pressure variation increased and the stroke volume variation increased, as you'd expect by giving a vasodilator. You're decreasing your effective blood volume. You're making yourself appear to be more volume responsive. But before she gave it, the pulse pressure to stroke volume ratio was 1.44. Afterwards, it fell to 1.13. So by looking at the dynamic relationships between pulse pressure and stroke volume variation, I can predict volume responsiveness. Maj asked that exact questions of septic shock patients who were hypotensive yet volume responsive, and he wanted to ask the question, who would have an increase in cardiac output and also an increase in mean arterial pressure if they gave them fluid? They're hypotensive. And he showed that he couldn't predict whose blood pressure would rise based on their mean arterial pressure, their static pulse pressure to stroke volume ratio, or their systemic vascular resistance. However, their pulse pressure to stroke volume variation ratio nicely separated out those who would be volume responsive from those that would not. So I can now combine all of these things and look at my patients. So this is now the clinical part of the study. Maas et al. In Leiden, we looked at post-op surgery patients who were having left internal mammary artery grafts, and after they were stabilized, the cardiac surgeons wanted us to increase the mean arterial pressure by 20 millimeters of mercury to 90 to maintain perfusion of this left internal mammary graft, which is a common thing to have us do. And so we looked at the effects of increasing mean arterial pressure by approximately 20 millimeters of mercury on the hemodynamics of patients. Well, the mean systemic pressure increased in all of them. Right atrial pressure increased. The arterial and venous resistance increased. Stroke volume variation decreased in all. In 10 of them, cardiac output fell, but in 6, cardiac output went up. How could I have, for the exact same increase in blood pressure, cardiac output fall in some and go up in others? Well, let's take a look a little closer. The patients whose cardiac output fell had worse ventricular pump function to start with, as estimated by their stroke volume variation. It was only 9%, and it fell to 5.3. That's not a volume responsive person. They had a greater resistance to venous return, and they had a greater decrement of cardiac output than those patients who had an increase in cardiac output. The increase in cardiac output patients had a wonderful stroke volume variation, showing that they were truly volume responsive. And if you were to look at the actual data, when you gave the norepinephrine, you increase the resistance, so the slope of the line falls, but cardiac output goes up. So norepinephrine, yes, will increase mean systemic pressure. Cardiac output should go to D, but the resistance to venous return increased, so it actually went to point C. The stroke volume variation shows there was no change in ventricular function. What happened in those that cardiac output fell? They had a greater increase in mean systemic pressure, but their resistance was higher, And instead of an increase in cardiac output, they went from this ventricular function curve to that one because of the increase in afterload was the overriding factor. And you could have predicted it ahead of time by knowing the pulse pressure variation. If it was over 15%, cardiac output would have gone up. If it was under 10%, it would go down. Pacini from Xavier Monet and Jean-Louis Thibault's group asked the same question in reverse. They had septic shock patients who were now stable on norepinephrine, and they simply wanted to decrease the norepinephrine level by a fixed amount. And they found, to their surprise, that cardiac output didn't decrease very much. But using the inspiratory pause maneuver technique that I showed you earlier, they were able to show that if you decreased the norepinephrine, to nobody's surprise, mean systemic pressure fell. But the resistance to venous return decreased as well. And thus, the expected fall in cardiac output was much less than you'd expect because you increased the resistance to venous return. So based on all of this, I can propose to you a protocol that'll work in every patient that you've got. The first question you ask is my patient stable? If they are, have a nice day. If they're not, ask, are they volume responsive? Stroke volume or pulse pressure variation greater than about 10%. The answer is yes or no. But you don't stop there. You say, are they hypotensive and have decreased vasomotor tone? The answer is yes or no. Let's go through this. Is my patient hemodynamically stable? No. Are they volume responsive? Yes. Oh, by the way, that's half of the patients in shock. Half the patients in shock are not volume responsive. They are hypotensive and they have decreased vasomotor tone, defined as a stroke volume to pulse pressure ratio less than 0.9. You already know from Monge's study that their blood pressure won't rise if you just give them volume, because even though cardiac output will go up, blood pressure won't, and they're hypotensive. These people need simultaneously volume plus vasopressor. But even if they are hypotensive, if they got normal vasomotor tone, giving volume will raise blood pressure and cardiac output. How about the other side? The other 50% of all shock patients are not volume responsive. Are they hypotensive and have decreased vasomotor tone? If they do, they need norepinephrine. Who is that? That would be the septic shock patient who you've already fluid resuscitated and they're no longer volume responsive and they're still hypotensive. They need more norepi. But if they're hemodynamically unstable, not volume responsive, they may be hypotensive, but they don't have decreased vasomotor tone. The problem is between my two hands. I don't know what it is, but it's right here. Ventricular pump function, pulmonary embolus, tamponade. The problem is right here, and I would start an inotrope as I'm looking for the echo machine, and I could reassess that every 10 minutes. And this approach is now being used in 3 prospective randomized trials, 1 in England, 1 in Brussels, and 1 nationally in Spain. And we'll, and hopefully next year, be able to show you the results of this compared to routine resuscitation in patients in septic shock. And with that, I want to thank you for your attention. I'll be glad to answer any questions.